This is a video of turbinoplasty done as a daycare procedure under local anesthesia, and we are using the RF ablation technology from bonds. So there is special indication for this kind of turbinoplasty. Turbinoplasty can be done by various techniques, like I normally do with microdebrider when this is done with a combination of septoplasty or FESS. But there are some cases where there is no septal deviation, there is no sinus disease, the patient is suffering only from nasal obstruction, gross turbinate hypertrophy, allergic reactions, wherein I give this option of office-based procedure, Coblation turbinoplasty. Here you can see first we injected saline in both the turbinates, and then I'm putting the RF wand. The RF wand has 4 marking in it. While using the wand, we see subtle changes in the tissue level, change of color, and how the tissue shrinks. But the actual effect comes much later. Initial 5 to 7 days there will be huge tissue edema, so the patient should be counseled accordingly. The desired effect will start coming only after 15 days, and the ultimate shape will be achieved after a period of 4 to 6 weeks. It is also important to take care of the proper local anesthesia. I just use some neuropathies or cotton weeks soaked in 4% xylocaine and adrenaline and place it into the nasal cavity under endoscopic guidance 10 to 15 minutes before the procedure, and that gives adequate amount of anesthesia. Usually this procedure is painless. Post-op, I put them on a short course of antibiotic, saline irrigation, nasal decongestant, and oral steroid in low dose for few days. And the wand can be used multiple times. While inserting the RF wand, you have to be careful that up to what length you are covering. Sometimes if it is not done carefully, it may hit the nasopharynx or it may hit the concabulosa or the middle turbinate. Your assistant can hold a nasal suction cannula in the entry point so that the fume is not obstructing your view. There is no hard and fast rule that how many tunnel one can make. That depends on the length and the amount of hypertrophy of the turbinate. I normally end up making 2 to 3 tunnels, one after another. The first tunnel I want to cover the posterior end because most of the time the recurrence or the persistent symptom happens because the posterior end of the turbinate is not addressed. And then I come anterior. Now we are doing on the left side. You saw the right side first. And the procedure being very simple and office based, there is always chance that after a year or so, if the patient wants a second sitting, you can again do in the same way.